Our program today is offered by the Physiotherapy Working Group of the European Huntington's Disease Network, with support from the Huntington's Disease Association. And our Physiotherapy Working Group is made up of several work streams. And the work stream that put this together today is our residential care work stream. Our goal is to help bring therapists together across Europe and other countries that work with patients with Huntington's disease, and to make sure that we're all up to date on the most current clinical practice guidelines, and to share tips and tricks that we've all learned from our practice with Huntington's disease. One of the first things we would like to have people do is place your country and profession in the chat. We would like to track and try to see how much of an outreach we've had with the talk today. And so it would be very helpful to us to know what countries were represented by our attendees. So if you could do that, we would very much appreciate it. Today, what we're going to do, we'll start out with a little quickie survey through the polling on Zoom, and then we'll get an update from our Physiotherapy Working Group. And then we'll start in with the overview of the physiotherapy guidelines for physical therapy in Huntington's disease. And then we'll look at promoting and supporting activity in individuals with Huntington's disease. And we'll talk very specifically about some tips and tricks from an expert in specialist HD care. And then we're going to have a discussion where we can all share our ideas and reflect back on what may be helpful with that. You should have the poll up asking some questions about what you've known about the clinical practice guidelines for physiotherapy and Huntington's disease. So if you can fill that out, that would also be extremely helpful for us, trying to report back on whether or not we were able to be helpful and what our outreach was. Feel free to continue putting your country and profession in the chat, and certainly continue to complete the poll. I'm going to hand it over now to Paul Carrion, who's going to give us an update on the EHDN's Physiotherapy Working Group.
Thank you very much, Deb. Our group work is varied and it's wide ranging, and we have members from all over the globe. I can see here that we've got some from Australia, we've got from North America and the Middle East and Asia. And with this, we try to support and enable, as Deb said, health professionals with the use of best evidence for the HD community, and with the use of clinical practice guidelines and encouraging physical activity. From a personal experience, we could all probably agree that HD is indeed one of the most challenging diseases, not only because of its rarity, but of its complexity of the symptoms that we have encountered in our patients, and of course the dynamic effect of it, of the familial the disease of the family. So in this webinar, we'll try, our first step is to connect and support each other through our experience. And of course, what is available out there, of what is the latest research, and how can best support and improve the care for people with Huntington's disease, specifically in the residential care. So this is one of our goals, to promote this through this webinar. And with the next step, we want to organize a physio working group task to develop and update HD resources to focus on HD progression, equipment, and mobility aids. Our lead facilitator with the physio working group, Una Jones, will later give her talk, and also would encourage everyone who would like to join our working group with these goals. Without much further ado, I'd like to introduce our first speaker. Our first speaker is a professor of movement sciences and kinesiology in the Department of Behavioral Sciences at Teachers College in Columbia University, USA. She is also a director of a neurorehabilitation research lab at Teachers College. Amongst many of her scholarly appointments and achievements, she's also the co-author of the Physical Therapy Textbook Documentation for Rehabilitation, a guide to clinical decision-making in physical therapy. Her earlier work and many of her works in physical therapy and Huntington's disease and other progressive long-term conditions, including Parkinson's disease, has been influential and widely contributed to the body of knowledge within research. She is an inspiring mentor and a strong pillar of the Physio Working Group. It is my pleasure to introduce Lori Quinn.
Thank you. Gosh, that's the nicest introduction I've ever had. It's so nice to be here. I would just like to say welcome to everyone. I'm not only thrilled to be here, I'm thrilled to see so many people from literally all over the world come together to help to understand how we can help people with Huntington's disease more effectively. I started working in Huntington's disease in 1992. The year before the gene was found. And at that time, I think there was an internet, but maybe just barely. And there was definitely no Zoom and no means to really interact with other people besides literally, I think, writing them and maybe sending an email eventually and picking up the phone and finding other therapists to collaborate with and to understand and to problem solve about how to work with people with Huntington's disease just wasn't available. So I'm thrilled that we have gotten to this point. I'm also so happy to still be a part of the Physiotherapy Working Group. I lived in the UK for 11 years, and now I am back in New York City, where I'm originally from. And I'm so happy that we have this very international group. So what I'm going to do today is share with you the physiotherapy Huntington's disease guidelines. We have done quite a lot of work with the HDN Physiotherapy Working Group, as well as there's a sort of parallel group, the Huntington Study Group in the US, on trying to develop guidelines for Huntington's disease. So I'm going to share a little bit about the history, and then I'm going to provide you with some of the kind of highlights of what the guidelines are showing. So we started off this work really in the kind of around probably 2008, 2009, and we had some publications that we put together that were really based on our best ideas, sort of experience in working with Huntington's disease, not so much based on evidence, because the evidence was really lacking at the time. So this is one guide that I really think is still a wonderful resource, which is called a physiotherapy guidance document. The working group put this together back in, actually, I think it was 2010, and it's freely available, and we'll try to get you all of these resources. And it provides information on assessments and interventions, and background on working with people with Huntington's disease, including how to deal with cognitive impairments. But what we realized was there really was very much a need for evidence to be able to support working with people with Huntington's disease. So we developed some clinical guidelines, and we've gotten to a point now where we actually have some clinical decision trees that I'm going to be sharing with you from a recent publication. But a lot of this work that we've gotten to at this point has been based off of a systematic review that we did and subsequent clinical recommendations, so clinical guidelines that were published in the journal Neurology in 2020. So the results from the systematic review and the subsequent clinical practice guidelines were that I'll just give you a quick overview here. We searched a whole bunch of different records, came up with 33 articles that were related to any kind of physical therapy practice for people with Huntington's disease. And we had 18 studies selected for the quantitative analysis and 2 where there was qualitative data. And what we found was there was the top level of evidence for aerobic training with or without resistance training, so strength training, to improve fitness and motor function, and supervised gait training to improve spatiotemporal features of gait. those are really the top levels of evidence. And what I want to say most importantly is that because this is a rare disease and because research is really challenging to do in this population, for not only because it's a rare disease, but because it's a very complex disease, the research is lacking. So the recommendations are only as good as the research. And we used a method to be able to produce clinical practice guidelines that actually gave us some flexibility so that we didn't have to have tons of randomized controlled trials to be able to provide evidence. So what we also were able to do was say there was grade B evidence, so a lower level of evidence, but still some evidence that exercise can improve balance, but we don't seem to have any indication that exercise can decrease fall frequency. That caregiver education is really important for maintenance of activity. Respiratory training is important for breathing function and capacity, and transfer training and skill-based training for things like getting up from down from the floor might be beneficial. So what we've done and how we've laid out some of our recommendations going forward is we've broken down some of the problems that people have with Huntington's disease into classifications. So as we all know, maybe if you've seen one person with Huntington's disease, you've seen one person with Huntington's disease. There's such a variation in the presentation of symptoms. And what we want people to think about when you see a person with Huntington's is to try to think about what are their primary movement-based impairments. What's their primary problem related to movement and activity? And we got together as a group and came up with 7 classifications that we thought that most people with Huntington's disease could fit into. These loosely follow the disease stages. So if everyone knows about the disease stages, right, there's pre-manifest or prodromal, and then it goes into sort of early, middle, and later stages. And I think where many of you are probably interested is sort of in this more mid to late stage where people are in residential facilities. But there's an important role for therapists to have in these early stages of the disease where patients might just have minimal motor impairments, but would really benefit from aerobic and strengthening exercise, ideally to prevent functional problems down the road. We know that bradykinesia and also balance problems really put people at high risk for falls. So we have categories related to that. And then as the disease starts to progress, some of the things that you all might be seeing are secondary adaptive changes and deconditioning. So for example, people with Huntington's disease tend to be weak. They have strength loss. That's not necessarily a primary problem from the Huntington's disease, but it tends to be a secondary change because of inactivity and deconditioning. We also see problems with abnormal posturing. I'm sure a lot of you are dealing with this, people's ability to sit upright in a chair or position themselves comfortably in bed, respiratory dysfunction, and then towards the very end stages, how we manage people in palliative care and thinking about being as comfortable as possible towards the end stages of the disease. So I just want you to think about this as a picture. And what we have tried to do is say, okay, if we have a person whose primary problem is sitting and abnormal posturing, we've been able to provide guidelines that are specific for that problem. So that's what I'm going to be showing you now. And all of this is in a paper that Nora Fritz was the first author on, published last year. And so what we have done is based on the categories, we've modified them a little bit, but we have what the participation restrictions are, what the impairments are, and what the recommendation is, and some intervention guidelines. So I'm just going to quickly go through these. So this is exercise capacity and performance. So physical therapists should promote aerobic exercise paired with upper and lower body strengthening 3 times a week for 12 weeks. For mobility and function, physical therapists should prescribe one-on-one supervised gait training to improve spatial temporal parameters of gait. For balance and falls risk, we all know that falls are a huge concern in people with Huntington's disease, but it's probably not something that we're very often able to completely prevent. But we do want to decrease the risk of injury from falls, and again, increase individuals' mobility and ideally their balance confidence so that they feel confident in moving around. So physical therapists may prescribe individualized exercises, including balance, delivered at a moderate frequency intensity to improve balance and balance confidence. And then respiratory function, so may provide regular breathing exercises, including inspiratory and expiratory training to improve respiratory muscle strength and cough effectiveness. And then with secondary musculoskeletal and postural changes, we may prescribe an individually tailored program to improve postural control and may use positioning devices to optimize posture. And then limited active movement. So this is sort of that end stage palliative care where we're going to be working on appropriate positioning, seating, family education, and caregiver training so that people can be as comfortable and have as high a quality of life as possible. So the other thing that I just wanted to highlight is that there are significant barriers and some things that are facilitators to engaging people with HD in being more active and mobile. And this really is appropriate in any setting. So getting people to be able to be more independent and active is really critical to helping to slow the disease progression. So one of the things that the qualitative analysis found in our work was that there are people certainly found physical benefits, but also social benefits to moving around, socialization and improved family and social relationships. But these facilitators are things like improving self-efficacy, identifying external factors that might increase people's commitment, like having a caregiver or a contact person. So that is really an important component. Having individualized plans and schedules. People find that intensive training is acceptable, and group exercises can be really beneficial for people, as I'm sure many of you know. And some of the barriers that we have to take into consideration as we're planning are the cognitive impairments, the significant balance impairments, and apathy or lack of motivation, and trying to find strategies to help work around that. And then I just want to say, as I wrap up, we really want to be thinking about different models of care in degenerative diseases in general, and specifically in Huntington's. This is a model that's been talked about in people with Parkinson's disease that talks about some different terms of how we think about rehabilitation. So PT, OT, and speech. So we are typically thinking of restorative therapy, I think, where we go in and we work with patients for a set period of time. But it's also really important that we work with people in the earliest stages of the disease and also continue to work with them throughout the disease, even if it's at a lower frequency, so that we can help to facilitate their mobility and their activity levels. There's a whole bunch of references for you, and we'll be able to send those out for people later if they're interested. And a lot of these articles are freely available or are on open access. So I will turn it over. I'm not sure who's next, actually, but thank you very much.
Thank you, Lori. That was wonderful. Next, we're going to hear from the chair of the Physiotherapy Working Group, Una Jones, and she's going to tell us all about how to keep people with Huntington's disease active and involve them in activity.
Hi, thank you, Deb. So yes, I'm Una Jones, and I'm based at Cardiff University, and I chair the European Huntington's Disease Network Physiotherapy Working Group alongside Deb Kegelmeyer and also Anne Cluse from Ohio. So I'm just following on from Laurie's talk in thinking about, well, we have these guidelines now. They were published in 2020. We've got recommendations. So how then do we put that into practice? And I just want to talk a little bit about the work that we're doing here in Cardiff that aims to promote and support physical activity in Huntington's disease. So, sorry, starting off, I just want to think about, well, why that focus on physical activity? Well, if I pull out the recommendation that physical therapists should prescribe aerobic exercise and the fact that this is grade A evidence, this is really around exercise, excuse me, to improve fitness and to stabilize or improve motor function. Now in Cardiff, we hold an annual family day where we share the latest research with the HD community. And in one of those meetings, quite a few years ago now, one of the participants who'd been in one of the research studies that underpinned this recommendation said to us, well, I did those exercises during the research trial, but afterwards I didn't do it. And that's really what spurred me on to thinking about, well, how can we implement these guidelines in practice? How can we get the evidence out there? So we thought then of a much broader perspective and thinking about physical activity, which includes any movement as well as exercise, and how could we actually help promote that, support it in people with Huntington's disease. So I got some funding from the Huntington's Disease Association of England and Wales, which is hosting this today. And that funding enabled us to develop a physical activity tool for Huntington's disease. So this was a tool that was co-designed by people with Huntington's disease, their carers and healthcare professionals. And in its basic form, it's a two-sided piece of paper, or it is available in a digital form from the HDA website. And the purpose of this tool is that healthcare professionals can have a conversation about physical activity and exercise and support somebody with Huntington's disease to develop a physical activity plan. So this starts off then with the healthcare professional, and it could be a physiotherapist, it could be an OT, it could be a nurse, it could be a carer, having a conversation about physical activity and talking about the general benefits, general health benefits, improving quality of life. And then what the evidence has shown, and this evidence comes from that systematic review that Laurie was talking about. And although it does, the evidence isn't that we improve balance, but there can be an improvement in balance confidence. So we can talk about the very specific benefits of exercise for people with Huntington's disease. And then thinking much more on a physiotherapy perspective, thinking about the types of physical activity and exercise. So we can talk about fitness or aerobic exercise, strength, flexibility and balance. And then thinking about where those activities could happen. Now, if we're thinking of residential care, actually it spans quite a range of people with different physical abilities. You may have people who are very physically able, and therefore the conversation might be a lot more about moving around outside of that residential care facility, or it could be that they're relatively limited and we're thinking more about moving around in home. So this is about giving examples of how there could be more movement in and outside the home. And then once we sort of gathering some confidence with the person, getting that rapport going with the person, we can then start the hard work of making a physical activity plan. And the key to this is being person-centered and asking about what's important to them, what would they like to be able to do. Now, what we'd like to be able to do may not be specifically physically active orientated or exercise orientated. It could be that they want to join other people in the care facility for their food, or that they can be in the garden with their family when they come to visit. And what we can do is tag on physical activity to their other goal. So this conversation on this side of the physical activity tool is about thinking about what's stopping that person, what support do they need, what advice do they need, and then thinking, right, okay, what will they do, how often and where, and how would they track their progress. So this is written in language that can be used by many healthcare professionals and maybe carers as well. But from a physiotherapy perspective, what we can see is this page is to do with goal setting. It's about frequency, intensity, type and timing of activity, and it's about facilitators and barriers to activity. So it's bringing in all that research, but presenting it in a much more usable way. Now, we're also very aware that healthcare professionals working with people with Huntington's disease may not have a wide range of experience. They might be new to the field, or it might be the only person they've ever met with Huntington's disease. So what we actually did then was develop a user guide. Sorry, when I blur my screen, oops, I need to have this back here, don't I? We have a user guide, and in there we have 12 different scenarios across the spectrum of the condition. So this is just an example of somebody who's in a care home. So we've got these little scenarios about a person. And then to help the healthcare professional, what we've done is completed some physical activity plans, so that if this is something that you're new to, that you can think, oh, that's an idea, I hadn't thought about that. So it's supporting the healthcare professional to support the person with physical activity. So when we developed this and we trialed its use within a Huntington's disease clinic, the feedback we got was, I'm not sure that the clinic is the best place for this. It may be more usable within the community. And therefore, the next step was, well, how can we actually translate this tool into helping people in community? And so this was the next study that I did, which is coming very soon. We're in the very last stages of doing final corrections of a carer's resource. And again, we have it in paper format, but it will be available on the HDA website. And it will be available in a range of languages, in English and Welsh and Spanish and Italian, Polish, Dutch and Swedish. So the whole carer's resource is translated into those different languages so that it can be used across Europe and for people who speak different languages within, say, the UK, Australia, or America as well. So what is this carer's resource? Well, this was co-designed, similar to the CAT-HD tool. It was co-designed with carers, and we aimed to get carers from residential care homes, but unfortunately we couldn't do that because we were just coming out of COVID at the time and it was really tricky. But we did manage to co-produce with family carers of people with Huntington's disease. And alongside the Huntington's Disease Association of England and Wales and the Carers Trust Wales, we developed this tool that would help carers support people being physically active. So what's in this tool? Well, we've got some background and safety and aspects like that. But importantly, what we included within it quite early on in the tool is, how do you get started? How do you support somebody to get started? And we categorize people into 3 different boxes here. Somebody who's never done anything before, somebody who's already doing something and wanting to do more, and somebody who is quite active but is now finding it more difficult. So we just got some advice there for the carer to chat through how they can actually use the book or the resource if they're using it online to support developing a physical activity plan. And within the carer's resource, we have a series of exercises. So we've got them in booklet form, which you can get from HDA, or they will be on the website. And these are exercises, the exercises are taken from the Move to Exercise video, which is on the HDA website, and some additional ideas that have come from the co-design approach. So we've got all those exercises in there. And then what we got from the feedback was, well, actually, if somebody has 10 minutes, 20 minutes, 30 minutes, what could they do in that time? So we created little snippets of activity in 10, 20 minutes, 10, 20 and 30 minutes, and also gentle, moderate and strenuous exercise. So we've grouped together exercises on flexibility, on balance, on strength and relaxation. And these are grouped together within the resource. And very importantly, what we added in the resource was a diary, because what we know from the evidence and from the people in the co-design is having a plan is so crucial for somebody starting physical activity and maintaining that physical activity. And having this somewhere that is meaningful to the person. So one of the people in the co-design group saying, well, we look at the diary on Sunday night and we plan out what's going to happen during the week. So you can, within this diary, you can plan what the physical activity would be, the exercise or the rest, but also taking into consideration other things. Is there another event happening that day? So you don't want to overburden the person. And then importantly, about whether that person actually enjoyed the activity, and that might help planning for the next week as well. So we're really excited about this carers resource, and we do hope that it will help to support people with HD, be physically active. So what are our next steps then in this project? Well, yes, we need to get it onto the HDA website, which will be very soon. I'm aiming to go to the European Huntington's Association conference in October to disseminate there. We really want to work with care homes as well to see could this be used within care homes, or some adaptation of it be used in care homes. And really importantly, we're looking to develop some case studies of people using the resources. And this is that we can share across the community, but also that we can get some feedback as to whether this is actually working or whether it needs further amendment. So I'd like to give massive thanks to the funders for the research that I carried out, and that's the Huntington's Disease Association of England and Wales and Cardiff University. Everybody involved in the co-design. I think I've mentioned most people, but importantly, my co-researchers, Katie Amana and Monica Busa. And thank you all for listening. And I'll be taking questions at the end. So thank you.
Thank you very much, Una. Also would like to invite everyone, if you have any comments, questions, or chat for Una's and Doris talks, we will have a discussion later on. But please, for the time being, please use the chat function and we can address them later. So we're on now to our third speaker. She is a passionate physiotherapist with over a decade of clinical experience working with people with HD and their families. She currently works in Huntington Center, Topaz, Overdien in the Netherlands, a specialist care facility for people with Huntington's disease. She likes working with HD from all stages. And in her own words, she emphasized the importance of building relationship with the person. For no patient is the same, and it is always a puzzle. An expert clinician within inpatient and outpatient settings with extensive experience specifically addressing the behavioral issues alongside the therapy management. On her spare time, she loves traveling the world and plays field hockey. Without any other things much to say about her, it is my pleasure to introduce our third speaker, Stella van der Niet.
Thank you, Paul, for that really nice introduction. Let me share my screen with you so I will tell something about my work as I do as a physio. I'm working for 4 to 5 days a week with patients with Huntington's disease. Let me see. So as Paul said, I'm Stella van der Niet. I'm a physiotherapist and I'm working on a complex behavior ward, and I'm also working with outpatient clinic and treatment. I will tell you briefly something about the location I'm working. In the picture, you see the residence care home where I'm working. You see the shape of an H. That's our new building who's now being built. And that's only for Huntington care. For now, we have 77 residents living with us. Also, we have 25 day treatment patients who are still living at home, but coming of a minimum of once a week to us for activities, lunch, and being together. And next to that, we have 110 polyclinic patients who are also still living at home and coming to us for having treatment of healthcare professionals. So physiotherapy and Huntington's disease, how do we work with it? Our main goal is to maintain the autonomy and quality of life of the patient with Huntington's disease. So we dare to take well-considered risk if this contributes the quality of life. So we always look at the patient. What do they want? What do they need? And what can they do? So we always first look on what can they do. And then from there on, we build their confidence back that they hopefully can do a little bit more, and then they stay more active and give that confidence back. And a physio here also assists with solving walking difficulties. So these are kind of the things we do as a physio here in Overduin. So through all stages of the disease, we try to give them the training what they need and what they can do. So we always adjust the training on their level. So what we do is endurance training, resistance training, balance training, sometimes in combination with dual tasks. And task training. So we walk up and down the stairs, and really important, standing up. So we teach them, preferably on this like early stage of the disease, how to stand up, and repeat that like a lot, sometimes every time we see them, because we see in a later stage of the disease, because of practicing, they still know how to stand up. And that was really like, it helped them a lot later on in the disease. And we also give them an advice for shoes, walking assistance, transfers, and body position in bed. And we do that together with the OT. So for example, endurance training, how do we do that? So as you can see on the photo on the right, this is our brisk walking program. And we walk for like an hour and a half, and we walk like 3 to 4 kilometers through the dunes. And sometimes we use a treadmill to train the endurance training. And if they can't do that anymore, we try to walk with them with 1 or 2 carers or a walking assistance. And of course, we're in the Netherlands, so we use a bike a lot as well. Sometimes we have a shared bike that we're sitting next to each other, and they still are able to bike outside. We use a home trainer, and we also use a motomed. That's the picture with the one in the wheelchair. So they're still in a wheelchair, but like you put them in front of the motomed and they can move their arms or their legs or both. So what we do with balance training, we try to use daily activities like reaching up, reaching sideways or to the ground. And we start with things they are still able to do and give them their confidence. And if they have their confidence of that exercise, we try to make it like more difficult for them. And how we do that, it's like we try the wide to narrow base of support, static to dynamic activities, and low to high center of gravity. So we do some standard tests to monitor and evaluate the balance and walking, etc. And the standard tests we do is the time up and go, the Tinetti, and the Berg balance scale to see if they have a high risk of falling. In this slide, you see the cutoff points we use if we give an advice about the use of a walking device, or see if they have like a high risk of falling. But we do look further than only numbers. Like the clinical view of the physiotherapist is always leading. So we look at the wishes and the needs of the patient and the quality of life. Like for example, we have a client who has like much lower points on their Tinetti and the Berg balance scale, but she's not walking with a walker or anything. This person falls regularly, but the quality of life and the autonomy is the most important thing here. So she's like not walking with any assistance, falls regularly, but has a higher quality of life because she is still able to walk and is not placed in a wheelchair. So yeah, what I said, it's important to have your own autonomy, and it will be easier for the person with HD to learn to use a walking device earlier in the disease process rather than later. And therefore an early introduction is recommended, even if the device is only used sporadically. But yeah, later in the disease, people with HD are often unable to use devices due to cognitive issues and may do better walking with assistance of 1 or 2 carers. And like, what are the indicators of a higher risk of failure? So for example, low walking pace, because when the speed is low, they need more balance, and people with HD has like their balance is not really good. So you can imagine if they walk really slow, they really need some balance, and that gives a higher risk of falling. Also, a smaller or variety in step length, a wide gait pattern, bradykinesia, chorea, dystonia, reduced anticipation on dual task, and a reduced static and dynamic balance. Really important also to wear the right shoes. So what we are looking at and what we advise in shoes is a firm flat heel, a bendable forefoot, a wide heel base for increased stabilities, a firm heel counter that keeps the heel supported, and a high top sneaker or shoe are recommended for ankle support. And we really try to avoid thick soles, thick toe grips, and flip-flops and high heel shoes. The photo you see here on the right, there are tailor-made shoes by our shoemaker. My patient had the pink ones, but then she lost her fine motor skills in her hands, so she wasn't able to tie her laces. So she needed help from a nurse. But she said to me, like, I really don't want any help with anything. So we find a solution for her, and you see the top photo. We used some Velcro shoelaces, and now she's able to put those shoes on by herself. I give you some examples what we also use in the resident care. It's a Huntington chair. It's a big chair, but it's soft chair. So when they have a lot of movements, they don't hurt themselves from a chair. Or when they have the movement backwards, the chair won't fall over. And it gives them a little bit of relaxation in that chair, sitting a little bit backwards. And it got its wheels underneath, so you can like just little distances you can travel. So it's not like a real wheelchair, but it's just a chair what you can move around in the room. We also have shower assistances. So if they're not able to stand up in the shower, we use chairs. On the left side, you see just a higher chair, so it's easier for nurses to wash the patient. On the middle photo, you see the carendo. We use that in the shower, and you can move the angle from it, so you can put it up straight, but you can also move it a little bit backwards. And then on the right side, it's a shower stretcher, so you move that patient into the stretcher, and then you fill it with water, so it's a little bit of a bath. You wash the client, pull the plug out, dry them, dress them on that stretcher, and move them back into the wheelchair. So really take the following into account when you're working with people with HD. Chorea increases due to stress, anxiety, and exhaustion. Increase of dystonia by dual task. So I'll always make sure that they do one thing at a time. And if you ask two things from them, the dystonia will increase. For example, I had two nurses helping the client, and they both were trying to put a sock on. So there was like one on each foot. And that like really got some stress from the patient. So really keep it with one task at a time. The dystonia can cause pain. So they can say they have like pain caused by dystonia. And the patient can experience intense chorea, but do not consider it to be problematic. So what I have a client, and I thought, oh my God, it's like he's moving a lot. He's walking against the door, to the wall. He drops things. And I talked to him, and he's like, no, it's no problem. I'm fine. And I thought he had a problem with it. But just by talking, I understand, like, okay, it's a problem, but it's with me and not with him. And it's still safe. He's walking. He's not like falling all the time. So it's fine. And some tips for a physiotherapist working with HD patients, just give the advice to the patients to stay active, because they need strong bones and strong muscles, especially later on in the disease. And pain caused by dystonia doesn't do any harm, so they still can move their body if it's the pain from dystonia. and set functional goals instead of goals based off symptoms. So don't set a goal like they want to I want to build strength, but say I want the patient to walk from the room to the dining room, and what do I need? Are the shoes okay? Is his strength okay? Is his endurance okay? Is his body's posture okay? So really set functional goals and all that together with the patient to confirm if that's the right goal for them. And when you're supporting them while walking, give them space to move around and move at their pace. So if you go really fast, that won't do any good for the patient. And try to keep the range of motion when they have dystonia. So do exercises with them to keep that range of motion, because what you don't use, you lose. And especially with the later state of the disease, they need to be washed by nurses, and they need that range of motion then. And by severe dystonia, be aware of pressure ulcers. And my main message I want to give to you all is don't be afraid of falling. That's part of the Huntington's disease. So yeah, thank you for your attention.